Welcome, friends, for this particular session. This particular session is designed to examine how we would like to manage the patients of hypertension who have or who may be having or who may be in the incubation period with high blood pressure. In fact, I'm sure all the people who are on board here already might have been inundated with information on COVID, not only from India, but across the world. Morning, afternoon, and evening, you open the print, you switch on the TV, you go onto the internet, you go onto any website, you would have information. As we see here, that COVID has become a part of your life, and when we design our medical care, it has to be with or without COVID. In that context, it will be worthwhile to examine that, when we see a patient of hypertension, and when we are managing a patient of hypertension, when we diagnose a patient of hypertension, or when we discharging a patient of hypertension, how we would like to, manage such patients. Also, we would like to add on a few things about diabetes also, so that, we are kind of cater to the needs of patients with hypertension and metabolic disorders when we have a COVID on board. Now, may I request my colleagues across the country to introduce themselves and give a brief perspective of their own experience of this particular pandemic that we have. Dr. Tiny, to start with, please.
Good morning. I am somebody's session. Okay, right. Oh, that's right. So I'm Dr. Tiny Nair. I head the Department of Cardiology at PRS Hospital, Trivandrum, Kerala. Trivandrum is a very small but scenic town. Do come sometimes once the COVID is over for a holiday. You'd really enjoy. I think many of you would have come here. I'm a practicing cardiologist. We are part of the same society, same forum that Dr. Naraj Desai belongs to, and we share so many common platforms, and we have been knowing each other for decades. I think as cardiologists, we have very little personal information or experience of managing a COVID, but obviously we are all updated as to what all expect in a COVID. And the one-word answer for hypertension would be that perhaps we should be careful in managing hypertension these stages, because hypertension is such a common comorbidity in COVID.
Go ahead, Dr. Akshay, please.
Yep. Good morning, everybody. So I'm Dr. Akshay Mehta from Mumbai, and I am an interventional cardiologist at Nanavati Hospital and Holy Family Hospital. And these days, I'm doing a lot of consultation on the cell phone and the media, because it's become now kind of a necessity. And of course, hypertension is of interest to me, besides the adult. And we are, of course, going through a challenge, and probably a little change in kind of practice maybe we will see in the future with this experience of COVID-19 infection. Okay, so thank you, and hope we'll have a good session today. Thank you.
Yeah, Doctor. Next one, please. Shilanjan.
Hello, I am Dr. Shilanjan Roy. I am practicing as an interventional cardiologist attached to RG Kar Medical College and Hospital in Kolkata. I am also attached to North City Hospital as an consultant cardiologist. I applaud the initiative taken by this forum to focus on the issues of hypertension and diabetic patients in this era of COVID pandemic. It is definitely a pertinent issue. And because we cannot directly reach to our fellow colleagues and peer groups through other forums, I think these types of webinar will go a long way in educating and enriching us with, knowledge. Thank you.
Thank you, Dr. Shilanjan. Now, whenever a large series of case reports or cases are in observational studies are reported, it has been found at least about 10 to 15% of patients with hypertension are always there in the sicker patients who are admitted to this hospital. Now, there must be some reason why patients of hypertension should be getting affected much more than non-hypertensive patients. I guess if it happens to be a risk factors, I guess, mind you, that there's a large majority of patients who may not have hypertension, who may not have diabetes, who may not have cardiovascular disease. They do develop COVID infection. But at the same time, it is known clearly in large studies that at least about 10 to 15% of patients with hypertension have this problem. To address this issue, what could be the underlying mechanisms of a patient with hypertension may develop COVID infection? Are there any thoughts about it, Dr. Tiny? You would like to put some light on that?
Yeah, I think this has been troubling us for some time, that we see that COVID patients tend to have more of hypertension, they tend to be more diabetic, and they tend also to have more cardiovascular disease. Now, we can always say that, since this tends to affect more elderly, and since more elderly patients would have hypertension and diabetes and cardiovascular disease and probably COPDs, they are likely that this cohort has more of these problems. Apart from that, is there a reason that we can connect? Maybe in a couple of two ways. One, initially at least, we were thinking that we know that this virus, those spikes on the coronavirus, they're so popular now in every movie and every picture, they get entry into the human system through the ACE2 receptor. Now, angiotensin 2 receptor is a transmembrane receptor that resides on the bronchial cells, and they have like a tail, transmembrane. So they sit across the cell membrane, and one edge of it projects out. They catch the COVID, the coronavirus SARS-CoV-2 easily and internalize. So, is there a point in thinking that hypertensive patients, especially those on ACE inhibitors or ARB, have a higher chance of COVID? Today we know that data is wrong. We have enough recommendation from societies telling that there's nothing to really do with an antihypertensive drug and susceptibility to COVID. We'll take that up a little later. But the other thing is, understand that we have migrated from an area where a couple of years back we were talking about hypertension being a hemodynamic problem, right? Today we say hypertension is an immune disease. It's not just hemodynamic where we dilate a renal artery and the hypertension is gone, right? So today we are talking about the central sympathetic system overdrives the kidneys, and the kidneys in turn changes our macrophages, our dendritic cells, and we have an immune response setting up, especially around the perinephric fat, around the renal arteries, and that might be a thing that pushes hypertension. Now, in that line, I would start guessing that can it be that there is some general immunodepression in these patients which makes them susceptible? We don't have an answer. All that we know today, and we can say confidently, is there is comorbidity and association between COVID, hypertension, diabetes, and coronary artery disease.
Yeah. Having said that, the way in which we recognize hypertension, and when we measure the blood pressure, we have to take care of ourselves. Now, do you have any practical tips about getting the information of patients' blood pressure? Dr. Akshay, you want to say anything about it? Blood pressure measurement in a patient who has got a possible COVID, just the kind of general remarks about it.
Well, first of all, encourage home blood pressure measurement from the patient, and for both protection as well as for enabling multiple readings, and then taking kind of a decision about treatment. So I think home readings should be encouraged, and if they can't do it, one can always tell them how to get a BP instrument, a good validated BP instrument, and that way one can go. If the patient has to come to the clinic, then of course all the precautions about mask, gloves, disinfection, keeping distance, all those precautions, keeping patients not crowding in the waiting room, all those precautions should be taken. And I think then one can treat. So these two ways one can measure the blood pressure and treat the person. And I think the measurement with the mercury instrument, etc., already was discouraged, and now all the more, because the patient can be given digital instrument and he can take it himself in another room, which may be a better idea, and which will also help a little bit of distancing. And then, of course, all the care about prescription papers and touching tables and all that, all those things have to be taken care of, I think.
Okay. Now, having had this blood pressure measurement on hand, we have a blood pressure reading of something like a 140 by 95 at your office, or the patient says. Your approach to this particular patient is different in this era when compared to the previous era, saying that, look, this patient is a potential to develop COVID infection. What do the panel say? What is your advice? You can, Srijan, you can, Dr. Roy, you can join in for this particular point also. In case.
It is, I'll take the cue from Dr. Nair, that Tiny sir, what he has told, that probably I think it's a clang association, because most of the COVID patients who are admitted in the hospital will be elderly individuals, already having multiple comorbidities. So it is quite natural that mostly those patients will be suffering from hypertension because of epidemiological reasons only. So I don't think a 10 to 12% incidence of hypertension in the patients who are admitted with COVID in hospital is something very serious to worry about. It can be quite a natural phenomenon. So there is no point in making patients panicky to tell them to take additional precautions if to a hypertensive patient that they have got increased chance of contracting COVID infection, as far as my idea goes.
Fair enough. What about Dr. Tiny? Yeah, go ahead. Dr. Tiny,
I think absolutely right. So simply because we detect somebody's blood pressure as 140 over 95 today, it does not make him, in this COVID era, does not make our judgment in any way different if we are detected in a pre-COVID era. So we should not simply, because we have detected 140 over 95, should not say that you are susceptible to COVID. And I fully agree with Dr. Shilanjan that, this must be a plan effect whereby a group which is more susceptible is this one who had hypertension. That doesn't mean that any patient who comes and gets a little hypertension, we should be jittery or we should be over-treating, or on the other hand, it should not be treating thinking that my RAS inhibitor might create a problem. I think both sides.
With this, the drug selection, some kind of issue or some kind of a controversy, with this kind of blood pressure, 145 by 95, you tend to push the lifestyle more, and more about the drug, and selection of drugs will become a secondary issue. Any points about it? In other words, a 145 by 95 should be treated as you would be doing in pre-COVID era, as all the panelists are saying. Now, in case the patient has a left ventricular hypertrophy with 145 by 95 or 150 by 100, our approach to this particular patient of hypertension with hypertensive heart disease, will it change?
Can I tell some?
Yeah, go ahead.
I think, sir, if the patient has been first time diagnosed hypertension and you get evidence of target organ damage in the subclinical TOD in the form of left ventricular hypertrophy maybe. So the first thing we should definitely, as a cardiologist, it should be kept in mind that the person might be suffering from mast hypertension itself. Person might be harboring hypertension for a long period of time. So it will be prudent to advise the patient for home blood pressure monitoring. If possible, I don't think it will be very urgent because it's not a very acute condition. We cannot reverse the LVH either acutely. We can advise the patient to go for an ambulatory BP monitoring later on after this phase is over. And then, make his treatment strategy likewise. Sure.
Do you have, Dr. Akshay, any difference of opinion on that? Dr. Tiny has the point, as I can see.
Yeah.
I think many often the treating physician forgets to understand that left ventricular hypertrophy by an ECG is a very potent criteria, very potent image that tells us that we are doing with a very high risk case. Okay, increased chance of stroke, increased chance of cardiac failure, increased chance of CAD, everything. And we see so often, oh, LVH. People forget about it. See, LVH is a very potent marker by ECG, whether you take Sokolov criteria or Corner criteria. ECG in a left ventricular hypertrophy in an ECG is such a potent tool for me to know that this is not the ordinary hypertensive patient. This is not just another person with a 140 or 95. We always teach our residents and tell them that if you have a discordance between BP recorded in office and the target organ damage to an out of office blood pressure, whether it's home BP or ambulatory BP. Because, for example, you have very high BP, and his retina is normal, no LVH, nothing, right? He might have a white coat. He should have a ambulatory BP. In contrast, his blood pressure, you are finding is normal. His significant LVH, his retina, his nephropathy, he has much hypertension. His nocturnal blood pressure might be pretty high, and he might be at a very high risk, not just of left ventricular failure or coronary artery disease, but a marker for dementia, right? Progressive dementia. So I think that patient should be treated. They should go for an out of office BP measurement.
Sure. Dr. Akshay had some point. You want to?
No, same thing. That once you have a blood pressure of more than 140/90, but with target organ damage or multiple risk factors, then both the guidelines, the European and American, both mention the treatment has to start right away along with lifestyle changes.
Sure.
So I think what Dr. Taini has said, yeah, same thing.
No, when you're measuring the ECG and when you want to do an echocardiogram, one should be careful in this COVID era. Okay, so all those precautions will have to be taken by the ordering clinician in case he is not sensitized to it. It becomes a difficult issue in this particular era. One should be concerned about it. Now, when we kind of diagnose high blood pressure, we find that the patient has a hypertensive heart disease, and when the patient has selection of drugs to be made by the doctors. I want to open this to the panel. What drugs you would like to use for this particular patient who walks into the office with no symptoms of upper respiratory catarrh, and his blood pressure is 150/110, and the patient happens to have left ventricular hypertrophy, creatinine of 1.1, and there's a microproteinuria. You want to select drugs for this particular patient. Although this was discussed a little while ago by Dr. Taini, it is worthwhile to go through. As Dr. Taini has alluded to, I'll request him to come back to us a little later. I'll start off with Dr. Akshay in case he would like to join for this.
I think the selection of drugs should be as the way we were doing it, like the first drug, either the ACE inhibitor ARB, and the important thing to note also is that in most patients, even with the stage 1 hypertension or as by the European guidelines, most of them will require a single pill combination of ACE inhibitor ARB plus a calcium channel blocker or a diuretic. Now, whether to withhold or not to give ARBs, ACE inhibitors in the COVID era is still, one thing is clear, that if the person is on a RAS blocker, not to stop it. That is what the guidelines have been saying. But to initiate drugs, maybe till we have a final verdict on the effect of ACE inhibitors ARB on COVID complications, it may be worthwhile as an initiating drug to try other drugs and see if the blood pressure comes down without any other side effects. So maybe I would change my approach in such patients and not give ACE inhibitors, RAS blockers initially, and see that if the blood pressure comes down easily without any side effects, then maybe till we get a final answer, we can put them on the other drugs. Once we get a final answer, or once, yeah, sorry.
What's your selection, Dr. Mehta?
In a young patient, if he has little sympathetic overdrive, though the beta blockers have been pushed back to the low level, maybe for a young patient, if there are no side effects, I mean, that of course has to be explained to them, then maybe a combination of beta blocker with a calcium channel blocker, which we were using so many years ago, before the ACE inhibitors, ARBs came. Maybe for a young middle-aged person, maybe that could be a starting point. And then we have diuretics to add on if required, if blood pressure doesn't come down. So maybe that could be the approach, would I think.
The information or the controversy bothers you, right, Dr. Mehta?
Yes, yes.
Okay, now let's go to the go to Dr. Roy about it. What does he feel? Yeah, one second.
Sorry, 1 minute.
I also...
Yes,
sir.
Yeah.
No, one thing. If the patient is already on a RAS blocker, I would not.
Yeah, this is the first time diagnosed. That's the specific question.
Yeah,
I would also tell the same thing, that if the idea in the mind of the cardiologist should be very clear cut, that if the patient is on ACE inhibitor, ARB for any compelling indications that him or her to be on ACE inhibitor, do not stop the medicine. That is the first message. Second message should be, in a patient of uncomplicated hypertension, patient who do not have any evidence of target organ damage, do not have any compelling indication to start ACE inhibitor ARB like acute LVF or ischemic heart disease or anginal symptoms, it is better to avoid ACE inhibitor ARB in an uncomplicated hypertension and try with other class of drugs like CCB or beta blocker, maybe in a diuretic where there is no chance of, dehydration or high suspect, already suffering from COVID. And in patients who will have, who are having compelling indications of ACE inhibitor ARB, hypertensive patient, post-MI patient, post-MI LV dysfunction patients, in those patients, I think we have to add ACE inhibitor ARB because the benefit much outweighs the incident risk. So that should be the three basic categories of the patient we should be very clear about.
Sure. In fact, just before Dr. Taini joins in for this particular aspect, I thought it is worthwhile to remember the adage that, what is proven in the biochemistry labs and the, animal labs may not be certain when we transfer that knowledge into the clinical medicine. In fact, that is the reason why societies have taken a stand saying that there is no harm in considering ARB and ACE inhibitors until at least further evidence evolves. Now, with those remarks, may I request Dr. Taini to put in his arguments as to what he feels about it at this moment. Or a patient who had those, profile and you have diagnosed it for the first time.
I will put it in a different perspective, a little different perspective. Let me see if I can put a slide. I will try to share my screen and put a slide with it also.
Sure.
Let us see if the slide thing works.
It should work. Hi, Gautam. You are able to?
Can you see that man there? Can you see my shared slide?
No, not it.
No, sir.
Not it.
No.
Hello?
Yes, sir. So share screen option is below.
Can you see the screen now?
So you will have to share the screen. You have to select share
Screen
screen.
is blank.
Can you see the screen now, a photograph?
No, not it.
No.
We are seeing Dr. Shilanjan.
Now we are seeing Dr. Nair also now.
Yes.
Sir, you have to open your presentation and then you have to share screen and select the file.
Any easier way to do that? In case.
Hello.
Siddharth, you are not having slides? Dr. Siddharth?
Hello.
Hello.
Some
Hello.
problem. I think some problem with the internet connection.
So there is some internet corrections problem.
Yeah, no issue.
Please
Let's
continue.
go ahead.
Please continue.
And Tiny, you can just discuss it as it is, I guess. Dr. Tiny?
Request sir to please continue. Seems Dr. Tiny has
He's
some
also disconnected.
connection
Right?
issue. Yeah, kindly continue, please.
Yeah, okay. When we are waiting for Dr. Tiny to join back, let's kind of divert our attention to yet another comorbidity that one often sees in a patient of COVID-affected individual. We see diabetes. And in combination with hypertension. And also we said that presence of cardiovascular disease make the patient more risk and at a higher risk of having events. Now, in case you have any thoughts about it, Dr. Roy, please would you tell us about your perspective on this particular aspect of COVID?
Definitely, sir. Many of the patients we will be seeing having concomitant diabetes as well as hypertension. We need to be more cautious about those patients. Particularly, I think diabetic patients should be counseled that they are at higher risk of getting COVID infection because of the immune dysregulation in those patients, immunocompromised state. And many of the cardio-diabetic patients in today's... Hello, am I audible?
Yeah.
Yes.
Right.
Yes.
Today's context, I think many of our patients who are suffering from cardiovascular element as well as diabetic will also be on SGLT2 inhibitor. That is a very important class of drug that we should keep a close watch on. So those patients at high risk of COVID infection or already suffering from SARI symptoms, which might be suggestive of COVID infection, we should always, warn those patients to stop SGLT2 inhibitors. If there is any evidence of concomitant illness during the sick days, it should be withheld and should have a close look on the possibility of development euglycemic ketosis. So those patients should have a periodic monitoring of their blood glucose, as well as if there is high risk of ketonemia, they should undergo urine ketone testing also, and prompt discontinuation of SGLT2 inhibitor time being. That is one important point that should be kept in mind. And already on the heart failure patients who are on concomitant diuretics also, along with SGLT2 inhibitor, and those who develops diarrhea or suppose COVID infection, which is also causing diarrhea in some patients, and subsequently they can cause dehydration. In those patients, reduction of diuretic dose or withholding SGLT2 inhibitor may be a prudent decision, depending on the patient's clinical scenario. So these two patients, these two things from cardio-diabetic point of view, I think it should be kept in mind. Also, we should have a low threshold of initiating insulin with proper endocrinologist guidance in the patients who are on OHA and has developed maybe COVID infection, switching them from oral hypoglycemic agents.
Sure. That's perfectly said. In fact, I'm glad. In case, in the sense, the use of prophylaxis, for instance, in case you would like to join in that discussion about the so-called hydroxychloroquine or chloroquine for immunoprophylaxis, for kind of prophylaxis for patients with the possibility of a COVID infection. How do you want to give give possibly a primary prophylaxis or as a treatment for COVID infection with hydroxychloroquine or a chloroquine from the cardiology perspective point of view?
I will keep in mind three things for my patient, I think, patients and myself also, regarding chemoprophylaxis. we are going by the ICMR guidelines and the state guidelines that have been provided, because I am treating patients in a government setup, in a government OPD. So I'll have to abide by the West Bengal government guidelines. And there have been clearly laid guidelines whom to take chemoprophylaxis, as we are treating patients who are having suspected SARI. So we have started chemoprophylaxis. For diabetic patients or cardiovascular disease patients, naturally there are a few standard precautions that needs to be taken. Firstly, hydroxychloroquine or chloroquine sulfate itself has got a hypoglycemic property. So a patient who has been prescribed on hydroxychloroquine and who is diabetic, naturally a risk of hypoglycemia should be kept in mind. Secondly, for cardiovascular disease patients, I think all the patients, even the healthcare providers, baseline ECG checking with monitoring of the QT interval is a must, as well as, warning the patients as well as the healthcare providers who are not very, conversant about the thing, that concomitant use of any casual use of any antibiotics like azithromycin should be strongly discouraged. Yeah. These 3-4 points we should be kept in mind. Risk of hypoglycemia with hydroxychloroquine, risk of QT prolongation, and definitely avoid overusage or indiscriminate use of hydroxychloroquine in normal persons.
Yeah, usually it is actually the primary care providers have been allowed to use the hydroxychloroquine with
Yes,
ICU.
We have already started, sir.
Yeah, sure. Very good. Excellent. I think we are going by the whatever standard practices at this moment, actually. When we have a patient of diabetes, diabetologists tend to say that they would like to switch the patient from oral to the insulin, preparations. I guess we'll have to go by the local practices, and it is said that they are better off with insulin rather than with oral hypoglycemic agents. And of all the drugs which are not very safe will be SGLT2 and also the metformin group of drugs. Now, as we go along, we see that, we are treating a patient of hypertension in this COVID era, and we will be reaching a stage wherein we will be reaching a stage of flattening of the COVID, and you start seeing the patients coming back to your clinic. Now we may have to have a second drug added or third drug added, and at this stage, what will be your preference then? In terms of the drug selection. Please join back. We are waiting for you. We came back to your question.
Yeah, so we will avoid all the slide stuff because the application is not stable. We'll just stop. See, a little different take on that. I'll tell you. Let's presume we have a 40-year-old man who is in hypertension. Okay. And this man does not have any risk factors. Means he has no diabetes, no dyslipidemia, no family history, no nothing. Okay. Second, this man, let's presume, has no target organ damage. No LVH, no CVAs, no retinopathy, no nephropathy, right? Number 3, he has no comorbidities. He doesn't have COPDs, no CLD, nothing. So this man doesn't have target organ damage. This man doesn't have a comorbidity. This man doesn't have any major different risk factors. This man, whether you treat with diuretic, whether I treat with ACE inhibitor, whether Shilanjan treats with a calcium antagonist, doesn't matter.
Doesn't matter.
Right. It only matters as long as we reach the goal. Right. He will do well.
Yes.
So you use whatever. We know with the huge data. You just make his blood pressure normal. As long as
sir, what is your take on the present scenario, in this COVID scenario? Whether you will start with an ACE inhibitor?
Give him. So now let us presume your patient has got either a target organ damage, or he has got additional risk factor, or he has got a comorbidity. Then the choice of drug becomes important. For example, if he has got an MI before, you have to give a beta blocker. If he has angina, you have to give a beta blocker. If he has a COPD, you have to avoid a beta blocker. If he has a diabetes, you have to give an ACE inhibitor or an ARB. If he has a nephropathy, you have to give an ACE inhibitor, right? So in that complex hypertension, who has either of these, anyone, we should still continue to give him the drug that he needs, because that will change his outcome in a big way. Okay, and that's another problem is the so-called ACE2 and all that. Should we deter ourselves from not giving the correct medication in this patient? So in a uncomplicated, simple hypertensive, you change to CCP. There's no point at all. But in this particular patient, like you said, like Dr. Shilanjan said very clearly, we have to give the right drug that he needs, not shying away from ACE or ARB or whatever it is. He needs the right drug. Okay, and for him, is there a problem? Today we have recommendation from all these 7 recommendations that has come up in the JAMA. Unfortunately, slides are not coming in. We know that that editorial and that write-up in JAMA, which came on the 4th of April, which was written by Frank Masali from Bern, Switzerland. Very clearly, there is no contraindication in starting or continuing these drugs. So I think it's very clear to my mind, if the patient needs an ACE inhibitor, like you said, a nephropathy or a diabetic, whatever it is.
Absolutely, sir.
I will definitely give it. There's no issue at all.
Yeah.
That should assist to all the physicians, all the cardiologists.
Yeah.
Yes.
Yeah.
Yeah, go ahead, Dr. You were saying something.
One point, can I
Yeah.
add? Are you all using HCQS, hydroxychloroquine? Because, we felt always that the data, despite the ICMR recommendation, the data does not look very strong.
Yes, the data is very much conflicting.
Correct. And if you have read that NEJM article that came on 4th of April, it has 63 patients treated with HCQS and definitely worsened outcome. Their ICU stay was longer. Yes, it is there.
Yesterday I got the copy of the study.
Yeah.
That study, what Dr. Shilanjan is talking about, that study shows that HCQS worsens outcome. And
it increased the requirement of ventilatory support in the patients who receive HCQS.
a drug that tends to prolong
Yes.
QT. See, people are arguing with me, telling that years together in malaria, we used to do HCQS without looking at anything, right? Such patients used to go home and die. They will still say, Dr. Saab, you have saved me. Today is not an era like that. You have not looked at the baseline QT. The QT prolongs for the patient and
Yeah, in fact, if one is not careful about the dosing,
very, very careful with it.
Yes, it can be a catastrophe, sir.
yeah, dosage and QT prolongation and sudden cardiac death has been reported from Karnataka. In fact, an anesthesiologist dying, taking inadvertently 1 gram of, hydroxychloroquine. He was dropped.
Casual intake can be absolutely detrimental. It should be strongly discouraged.
Yeah. In fact, I just wanted to check on how many of you depend upon the home blood pressure before COVID era to manage your high blood pressure patients.
I very much dependent. Very much dependent.
The only thing is,
go ahead.
the only thing is the instrument, the methodology, the
calibration,
time, all that has to be explained well to the patient, and then multiple readings over a week can give us a good guide.
Sure.
In different times of the day. I also encourage them to take the readings at different times of the day, not in a particular time, morning, evening, distributed over different times.
As a panel, do we agree that home blood pressure monitoring should be a standard of care in the modern practice of hypertensionology?
Yes.
Yes, absolutely.
And
yes, that's very good.
First step before going to NPM.
Yeah, go ahead. Dr. Tiny has something to say.
The point is, okay, see, we authored, just now published in Journal of Human Hypertension, the Indian study with 27,724 patients, the largest ever ambulatory BP data set, right? We all know that. But consider what percentage of your patient or our patients actually had a home BP. Despite such an advanced state in Kerala where we use so much of home BP, the percentage of our hypertensive patients are also huge. So the number of patients who actually percentage of get on home BP are so minuscule, right? So we know the problems of home BP, we know the problems of ambulatory BP, wakes you up. Every single patient will come and say, Dr. Saab, the moment it inflates, I jump out of my sleep, right? So it is not actually his night BP, but his night awake BP, right? So he wakes up, everybody wakes up. So we know the catalyst. Now we have a huge experience with ambulatory BP. So I think we should be in India, we should say pre-COVID. We should say in our mind, our indications for ambulatory BP are very, very clear. These are our indications. Unless we do that, it will add up to the cost and we will not be able to do ambulatory BP for everybody. How is it going to happen? So right.
Not ambulatory. No, not ambulatory BP. Home blood pressure.
See, out of office, if you take out of office, what percentage of your patients actually have the true home BP using that home BP instrument? It does not give a reading, take readings at a gap of 20 seconds, averages out morning, night, evening for 7 days. How many people does that? Okay, very few, minuscule, of the huge 15% hypertension we have in the population. So we should do that. We agree it's good, but then we have challenges. So I think post-COVID things have changed. I want to avoid meeting a patient. He wants to avoid traveling. He wants to avoid a crowded OP. So I think we should develop a system whereby out-of-office BP should get a priority. Yes, absolutely. But right now, the number of people who are getting are minuscule.
Okay. At the end of another 3 months' time, will the practice change now that you have used to having this home BP data and you rely upon it? And at the end of 3 to 6 months' time, will this change, revert to the original way, or will the physicians continue to believe and force the patients to use the home blood pressure data to make decisions?
In metros, it will change in metros, it will change in areas where educational levels are higher. But in the large rural population of India, I don't see that in 3 months' time you are going to see any change. Because our main challenge was the large rural population didn't even have one blood pressure recorded. And here we were talking about throw away the mercury, throw away everything, and look at digital, look at home. No, it works in a very small, minuscule. Your hospital, our hospital, Shilanjan's hospital, yes. Okay, in Mumbai, yes. But then beyond that, the reach is going to be extremely small. So if you take the 1.3 billion people, do you think any major change in 3 months? No, no.
Okay. Now let's continue that aspect, saying that your teleconsultation for managing your chronic conditions. Let's start off with Dr. Roy. What is the way in which you feel you're going to be in the future? Teleconsultation.
Frankly, sir, from my perspective, I am still not very. Familiar, or I'm not very comfortable in using teleconsultation till now. Only very few queries if the patient call me up or over WhatsApp, over telephone, that is okay. But a full-fledged formal teleconsultation platform, I'm still not very comfortable with it. Maybe in the near future I have to use it, but I still prefer face-to-face consultation, still looking my patient clinically, touching the patient. That is, I am much more comfortable with it. Maybe because we are all trained like that. But there will be some hindrance in using teleconsultation also. All things you cannot get in teleconsultation. You can get some laboratory data, you can get some basic BP recording, pulse recording like that. But still you can get a plethora of information seeing and touching the patient in your clinic itself. Even the gait of the patient, the look of the patient, everything, the way the patient speaks, it can give you some clinical clues that you will definitely going to miss in teleconsultation. So there are many hindrances. But naturally, with the evolvement of technology, with the new artificial intelligences, the new apps come out, these difficulties will gradually wane off. And it is naturally, I think it is futuristic. It will be more and more practice in days to come. But there are some medical shortcomings of it, as well as some legal drawbacks also. Maybe in the COVID era it is being allowed, but I don't think in the long term there will be some medico-legal aspects also using teleconsultation widely. So I will still take teleconsultation with a pinch of salt and go with my routine practice of consultation 1:1.
Sure, we'll come back to that with Dr. Inina's reaction to it, because I was seeing him, I was looking at him closely when you were talking. Let's see now what Dr. Akshay would like to do for his first practice in terms of telehealth and hypertension practice.
Yeah, for now I think in general, I think I would divide into the COVID era and the post-COVID era.
Yeah.
In the COVID era, even the initial consultation I would do with teleconsulting. I will give a small example. There was a 40-year-old lady who complained of breathlessness. And this breathlessness was a little odd. It used to come any time of the day, even while she was sitting on a chair, and many times walking a little will not produce it. And she had no comorbidities, no risk factors. But she was, I think, about 60, but a strong family history of heart disease. And a video calling helped me to find out And I told her, how can you just tell me how it feels like when you are breathless? So she said that she had to gasp for long breaths and as if she was not getting enough oxygen, and intermittently she had to take such deep breaths. And then, of course, I got her other tests done, all on the online, the HS Tropy and everything, and ECG, echo, everything was done, and everything was okay. And from the way she was breathing, I could make out it is more of a hyperventilation. And I mean, this I would not have done in the post-COVID era. I would have definitely brought her to the clinic. And so in post-COVID era, at least the first consultation has to be in the clinic. So we are missing the personal touch. Touching a patient is so important. All that is not there in this COVID era. But at least if there is any doubt, then one can go ahead and call the patient to the clinic. But one can always try a teleconsultation at the first. And of course, follow-up consultation is very easy, whether post-COVID era or COVID era, because in follow-up, it is just the question of pulse, blood pressure, biochemical investigations, all that. And here in Mumbai, especially, the long distances are a big problem for patients.
Yes.
Patients have to travel 1.5 hours, 2 hours for consultation, and then wait in the line. And it's, I think it's a great service that we can do, if we can do, by teleconsultation for routine things. Wherever there is a slightest doubt, of course, one should call the patient. So I think there is a initial, during the COVID era, the initial consultation at least can be tried on the video calling with reports and everything. If there is a slightest doubt, for example, a patient has chest pain, chest discomfort, there is no doubt that if it is a typical discomfort, to see the patient or get him investigated. But I think the COVID era is going to teach us how to use telemedicine and how best to treat patients.
If the patient has typical pain, yes, and you are sitting on one side of Mumbai, would you like to ask the patient to go to the ER of any particular hospital and kind of get the information for you from an ECG?
Okay. Talk to the doctor. Yes. Correct.
Sure. Yeah. Okay.
Absolutely.
Okay. Let's now hear Dr. Tiny's views about telehealth in the future, COVID and post-COVID. I like Dr. Akshay's classification of it and his approach. Let's hear Dr. Tiny's.
Yeah. Am I audible?
Yeah, you are.
Okay, right. See, all of us have been trained in a medicine. All of us are trained in a medicine where we take history from the patient, physically examine, look at his reports, tell him what it is, give a diagnosis, and then he goes home. This is all, we have been trained like that. So logically, it's very difficult for us and very painful to escape that situation, right? But do read that last week's editorial that come on digital divide. They say that this kind of brick and mortar thing exists only in medicine. Your insurance fellow has gone, your travel agent has gone, your bank has gone. They don't physically present them anymore, right? You are just virtual. Did you ever think about 20 years back that you travel in a flight without a ticket? Or have you ever thought that you will sit at home and on your cell phone book a ticket and just walk away? Or you thought that you will money transfer 2.5 lakhs from your cell phone? Right, so things have changed. Okay, now what they say is that, let's say, what is it now here? Our telehealth is now absolutely rudimentary. How many phone calls Dr. Nagaraj Desai or Dr. Tiny gets a day? Okay, 50, 100. Sir, I have this, okay, you take this. Yes, take that red tablet. No, what is that you take? We go on talking over the telephone or the WhatsApp, right? But that is not telehealth. The telehealth, and that, does it give you any financial input? No. So you are also not responsible. Patient also may or may not follow, and the legal aspects are not clear. That will go away. And I think COVID has acted as something that will hasten, as a catalyst that will hasten that change. See, imagine you are talking to let's say I'm a patient and you are a doctor. Dr. Nagaraj Desai is asking me, Dr. Tiny, how is the pain, sir? Some kind of pain. Is it in the throat? No. Does it radiate? No. Does it come at morning? Does it come when you exert? Does it come when this thing? Is it a pricking pain? So I'm sure you can, watching me in high definition, you can get all the history from me, right? And you can see my facial expressions. Only thing that you would miss out would be listening to a murmur or heart sound. That also today, Think Lab stethoscope has come, which will be delivered as a system. So the patient puts it here, puts it there, puts it in marked areas, and you can listen to the heart sound if you wish. Let us say physical finding is not there. Today, your wearable, right, gives you an SpO2, gives you an heart rate, gives you a blood pressure, gives you a temperature, whatnot. Every parameter, including whether you slept last night or not. Far more data than I can physically get, the wearable would give you. And then the investigation. Somebody would have gone out, taken blood, and then the investigation reports are ready. He flashes it right in front of you, or a PDF comes in. So you have sodium, potassium, magnesium, everything is ready. What else you need to make a diagnosis? You can make a diagnosis. There's more of mental that we are taught that when we are unable to make a diagnosis. So very, very clearly, even if you don't touch and palpate his liver, you have an ultrasound done. So once you have all the, we are not talking about acute cases at all. Chest pain, breathlessness, you have to go to a hospital ER. But chronic consultation, most of the things, now how it can be officially made, there will be an official thing. If my consultation in OP starts at 10 o'clock, exactly like this Zoom meeting, 10 o'clock, I am ready there sitting here. So 10 to 10:15, Mr. A calls up. He shows on the television and he has already booked my appointment by paying through his credit card. So he will not miss it. It's not casual. Dr. Saab, can I take? No. So he is present there between 10 and 10:15. I advise him, 10:15 the line cuts. Patient number 2 comes in. It will happen. It will happen. And COVID has asked as a catalyst, making sure that we go on to that era far more quickly than it happened. Have I transformed? No. I don't do any teleconsultation at all. Okay, right, apart from our WhatsApp and all that. But I see that this is a chance where all of us can migrate, especially with help of everything in pharma, and everybody realizes today, your hospital realizes how much of money they're losing, how much of income generation they're losing. I think we should quickly migrate on to telehealth. Yeah, absolutely.
Yeah, sure. Okay, then now let's kind of, we are in the final phase of our discussion. As I see that with the clinical scenario that we have discussed so far, at the diagnosis, at the management level, at the follow-up level, the options that when we have, and the selection of drugs that we have, and the controversy which has seemingly arisen out of the so-called ACE2 being kind of modulated or mediating the viral load into the cells themselves, and its present state saying that no need to worry about that at this stage, at least, is clearly kind of discuss all these points. Now let me just request each one of them to tell us any kind of individual patient's experience in this particular era and how they manage their patients effectively to make sure that the patient was satisfied. Let's start with Dr. Akshay, because he happens to be on the screen right now. Dr. Akshay, please, would you like to kind of give a couple of examples of your own practice wherein in the COVID era, you manage these patients of hypertension with or without any problems?
Well, hypertension patients, all of them have been treated by telecommunication, by their blood pressure readings, and most of my patients have an instrument at home, so they measure and they give me the feedback, the blood pressure readings. I tell them to take 2 readings in the morning after passing urine, and 2 readings at night, and on an empty stomach. And based on that, I guide them the blood pressure treatment. There was one patient who was of hypertension but had chest discomfort, which was very typical, and ECG was normal, but the pain was so typical that it happened at night on 2 consecutive nights. So I had to admit him, but we managed without doing any intervention with all the antiplatelets, low molecular weight heparin. Fortunately, his cardiac enzymes were normal. So we managed him just medically, did not do any. We said we'll post him for angiography later on, and he's been doing exceedingly well with just the medical treatment. So as far as hypertension goes, it has been very easy to treat. The other things, heart failure, chest pains, unstable angina, all that is a little difficult, but can be managed.
Okay,
So
when you are
I think
the TROPS and the COVID prognosis, because you mentioned about the cardiac biomarkers, and you did that in particular patient, in case the patient happens to have a COVID infection, what is the implications of these troponins and the BNPs in a patient of COVID infection?
If a patient has COVID infection, then things are a little different. You may be dealing with myocarditis, you may be dealing with infection, and then the troponin levels may not help you to pinpoint that it has a coronary disease, whether it is ischemic disease. So many times there have been patients who have come to the lab with ST elevation MI with normal coronaries, and they have been COVID positive. So there's a little problem there. Yeah.
You should use echocardiography, I guess, as you rightly point out, so that the wall motion abnormality index will also be helpful. And of course, the troponin, when they are positive, proportionately the prognosis also seems to be worse in the large observational studies which have been reported now. Now let's go to Dr. Roy to tell us about his personal experience and also his remarks on this particular topic today.
I want to add one thing apart from these hypertensive issues also, that in this present COVID era, one thing we should all keep in mind that other cardiac emergencies and other medical emergencies should not be neglected. They should not be, given a second fiddle. They should be, all the MI patients, all the NST-MI patients, they should be given equal importance. At times we tend to feel that because of more scrutiny, some patient might be not getting their due treatment in certain hospitals. Patient might be having slight rise of temperature, concomitant fever. One of my patient has been recruited from a hospital. He was having NSTEMI. He was having IV cannula for 2-3 days. Maybe because of thrombophlebitis, he was having some fever. I referred him to a PCI capable hospital for doing an angiography and revascularization if necessary. Unfortunately, in the ER room, he got his temperature checked by the thermal gun. His temperature came out to be 99 degrees and he was regretted to be taken to the hospital. That is very unfortunate. So I always, when I urge the healthcare providers, the hospitals also, to not to, any patient should not be neglected, should not be, they all should be given their due chance of getting proper treatment and timely emergency treatment in this COVID era. They should not be stigmatized. Okay, and proper screening definitely is very, very essential.
Got it. Okay, Dr. Taini, would like to add some additional issues, personal perspectives?
Dr. Taini has dropped due to connection. Kindly take questions.
Okay, now we are almost ready to take up the questions from the audience. I cannot read through this. Sorry. Damn it. One question that has been, kind of passed on here. Is there any specific antihypertensive which is contraindicated in COVID at all? We discussed this
already. Have discussed.
Yeah, we already discussed this. In fact, this is from Jayanta Shankar. And of course, is there any medication which makes a person more susceptible? One, Dr. Kamal Kishore, that he has asked. Again, there is no specific. You would like to take on this point, Dr. Akshay? Would you like to comment on this?
What is the question?
Any particular specific medication which makes a person more susceptible, more prone, more proclivious?
There are two things: more prone to infection, no, but more prone to complications of infection. There was a kind of doubt about ibuprofen and NSAIDs.
Yes.
Causing worsening or creating more complications. Of course, that also is still not proven, but one thing is sure, that NSAIDs can, of course, cause water retention, push the patient into cardiac failure, etc. So I think NSAIDs is one thing one has to be careful about. I think apart from that, yes, Dr. Roy.
Yeah.
Sir, you please conclude, sir. Then I will tell.
Sorry.
No, I am telling Dr. Akshay sir to please conclude. Then I will.
Go ahead.
Okay. I also want to tell that patients who are taking immunosuppressive drugs, suppose transplant patients, cardiac transplant particularly, they have mentioned, all the transplant patients, renal transplant patients, they should be absolutely careful, because they are at very high risk of contracting the infection. They should be properly isolated in their home or any healthcare facility where they are staying. And any routine or planned transplant, in fact, they have the ESC and the American College of Cardiology, they have also told that some cardiac transplant particularly, they have postponed in this COVID era. Because of the risk of immunosuppression they have to give following that event. So that is one group of drug that should be we keep in mind, immunosuppressants.
Sure. Very nice point, Dr. Raj. In fact, there is a question on use of ARBs again in hypertension. We already have covered. Hypertensive, hypoglycemic drugs, which are the ones which are contraindicated, that they should not be used. This also was covered by Dr. Roy very effectively and completely. And in fact, Dr. Shilanjan, do you suggest to discontinue SGLT2 inhibitors in all diabetic patients exposed to COVID infection? So what are the guidelines, Dr. Ravindra Kumar?
Not at all. If the patients are stable, there is no history of any exposure to COVID or no COVID patient in their home who are infected with COVID, no need to discontinue the SGLT2 inhibitor. But if the person develops any flu-like symptom, needs to get hospitalized, develops any dehydration or diarrhea-like symptoms, then definitely we need to switch from SGLT2 to any other class of drugs, or maybe insulin. But not all the patients. It's not like a blanket ban to all the patients who are receiving SGLT2 to stop SGLT2 and switch to other class. But for SGLT2 inhibitor, you should be cautious, particularly when the patient needs to be hospitalized or any ICU care, then it might needs to be changed. Also, there should be a caution exercise for metformin also. If the patient is at risk of development of dehydration, patient getting hospitalized, worsening renal function, then metformin should be discontinued. Substituted for other class of drugs.
Fair. Yeah, you're off. Doctor,
one class of anti-diabetic drug. One should not take hydroxychloroquine itself as a part for the anti-diabetic treatment as well as for chemoprophylaxis. It can lead to a serious problem. So that caution should also be exercised. These 3 points I want to add.
Yeah, okay, good. Excellent. All right, friends. In fact, when we are coming to the end of the session, I'm just looking for some additional questions from the audience here. In fact, these things, 1 second. Yeah. Should we change ACE inhibitors from hypertension patients? This already has been covered from Dr. Sandeep. There's a question. And Dr. Tiny has an issue with his net. Oh, no, we have already answered. So, whether beta blockers won't exacerbate dyspnea if the patient is diagnosed with COPD and hypertension. Dr. Navnil Gupta, he wants to know. And, Dr. Akshay, what do you think about?
Nani, what is the question?
Beta blockers, won't they exacerbate?
Sorry?
Beta blockers, whether they not exacerbate dyspnea if the patient is diagnosed with COVID. Because one of the symptoms of COVID infection is dyspnea. In case the patient happens to be on beta blockers, it may get worsened, isn't it? That's the question that is being posed to us. Dr. Akshay?
Well, if the if beta patient is already on beta blockers, I think we should continue beta blockers, but see how the blood pressure response is, how the left ventricular function is, whether there is worsening of heart failure. In fact, in many patients with heart failure who are on beta blockers, except for cardiogenic shock or very severe heart failure, beta blockers are usually continued, and one can reduce the dose for a day or two, but otherwise they can be continued, and other treatment has to be given, diuretics, etc.
Yeah.
So in the same way,
Yep. Sorry. Go. Anything else? Yeah, Dr. wants to make one point.
Yeah, the point is that, COVID patients become dyspneic not because of a bronchospasm, right?
Yes, absolutely.
These are fine. They have their alveolar problem. It's a viral problem. So they have alveolar hemorrhage, alveolar necrosis, So normally beta blockers should not be an issue in that. Probably the person who asked question was asking that there is a dyspnea and, like COPD, exacerbation, do you need to stop? There is no real indication unless you have something telling you that you need to stop a beta blocker, you can continue.
There's a question on CKD. CKD patient, what is the current guideline? What is the target blood pressure? Dr. Aminul Islam Khan. This is to Dr. Tiny specifically. CKD patient, what is the current guideline? What is the target blood pressure? CKD patient.
CKD patient.
Yeah. You are talking about CKD patient in hypertension. So we very clearly know that in CKD, it all depends on what amount of CKD or what stage of CKD you are talking about. But overall, CKD patients, if you are able to start them on a RAS inhibitor and they tolerate it, meaning that their creatinine clearance is not dropping by 25% lower or creatinine is not jumping about 25%. These are not patients of renal artery stenosis who tolerate a RAS inhibitor. Their graph of slowing down or their GFR decreasing actually comes down. So if they tolerate a RAS inhibitor, that would be the best. Understanding that we all know in a CKD, it is one of the worst situations to control a blood pressure, right? You use multiple drugs, still you won't reach a goal. What would be the goal? Obviously, as close to 120/80 as possible, but at least try to bring it down to less than 140, 190. But the point is, you might have to use a combination of a beta blockade, a calcium antagonist, a RAS inhibitor, provided that the patient is tolerating and not worsening in his renal function, and probably also an alpha blocker. But despite all that, you might have to go for centrally acting drugs to properly control blood pressure in CKD, and patient finally might need to have his volumes down by maybe a renal replacement therapy, like hemodialysis.
There is one question. Thanks, Dr. Tiny, for that pointing out. Persistent raised diastolic blood pressure above 100. What to do? Please let us know.
Yeah, this is one of the standard blood pressure, elevated blood pressure, diastolic blood pressure. But you would very rarely find that a person has a blood pressure of, let us say, 130/100, right? Most often, by the time you reach a diastole of 100, the systolic pressure also would be elevated. Isolated elevation of systolic pressure is generally seen in people who are elderly with stiff arteries, and they have a higher systolic pressure and a normal or near normal or lower diastolic pressure. This is the general elderly. We are not talking about the young fellow who is working in IT and has a tachycardia and elevated systolic blood pressure. In contrast, what you are talking about is an isolated diastolic elevation. Systole may or may not be elevated. These are patients where you can use anything. Probably as the ESH guideline is now, as you are aware, asks you to start on a combo, probably for most patients, combination of an RAS inhibitor and a CCB, or of course you can choose a RAS inhibitor and a diuretic would be a starting combo. Today we are recommending that if you start on a one pill combo for India, ideal would be to start with a combo of RAS inhibitor plus a CCB. Okay, so you have a RAS inhibitor, let's say telmisartan or one of the sartans, along with the CCB like an amlodipine combination to start with. And if the blood pressure is not controlled, or if you find that your patient has sinus tachycardia, In fact, in our the 27,000 patient data, we found that the baseline heart rate of Indians are far higher than the Caucasians. So we might actually tend to upgrade beta blockers higher compared to the standard guideline. So start with the standard therapy, RAS inhibitor, CCB. If not controlled, go for next generation drugs.
Okay. Now, in fact, this is a good question. Hydroxychloroquine prophylaxis is being taken by certain professionals, and on the same time taking beta blockers as their regimen, regular regimen. Any specific instructions from panelists focusing on arrhythmia and QT interval, please? Dr. Roy, would you like to say anything? Yeah, go ahead.
Ideally, it should have a compensatory effect because beta blocker will lower the QT theoretically. And if at all hydroxychloroquine increases the QT interval, it should have, counterbalance these two things. But in fact, there is no such contraindication. If the person is taking beta blocker, he or she can safely take hydroxychloroquine. But if the patient is on any antiarrhythmic drug, class 1C antiarrhythmic or class 3 antiarrhythmic, which is cause QT prolongation, then there should be a point of caution that their QT interval should be monitored closely. If the patient is on any antiarrhythmic drug and needs to, any healthcare provider needs to take hydroxychloroquine, or any patient who is already on antiarrhythmic drugs needs to take hydroxychloroquine, then close monitoring of QT with everyday ECG or every 12-hourly ECG should be prudent, or monitoring during that treatment of hydroxychloroquine for the first 5 days should be indicated or required, I think.
How do you measure the QT interval? Just a mundane question for myself and for the audience, Dr. Roy.
In digital ECGs nowadays, the QT itself is provided. The QTC at times in analog ECGs that we get, we have to manually calculate the QT and correct it for the heart rate. So that we have to manually calculate it. Otherwise, in most of the digital ECGs, itself the QT is calculated automatically.
I mean, I have my own slight disagreement is, when we have this computerized interpretation of these intervals and rates and all, it should be manually kind of
cross-checked,
adjudicated, because sometimes the so-called mild T-wave, T-wave changes or the U-wave appearance may kind of modify the readings by the computer.
Yes, definitely, sir.
Definitely, it has to be adjudicated by you. And
it is just for a basic screening. For a basic screening.
Yeah, sure, definitely. Okay, that's what the concern is, because many of the physicians may overlook that sometimes.
Yes. For physician, it might be slightly difficult, because for a cardiologist who is day in and day out seeing multiple hundreds of ECGs, it is easier for us to just get a glimpse of the ECG, get an idea who is having a long QT or not. But for a physician, it might be slightly difficult. So better go for a manual measurement of the QT to be on the safe side.
Perfect. That's what I would like to point out. In COVID lockdown, anxiety, panic, depression, impact on already hypersensitive patient. Please don't move that, Dr. Miss Minal. Okay. Of drug additional it missed out. I can't read it. Minalji, please don't move it unnecessarily. How frequently we can use hydroxychloroquine in a patient with hypertension with diabetes?
Already answered.
Dr. Tiny, would you like to say anything?
Same thing, already discussed. Was said in details. I don't think.
Yes, of course. Yeah. What you suggest to senior citizen patient on hypertensive drugs since 20 years, or CABG or plastic, to do precautionary measures, Dr. Santosh?
This would be same, simply because a patient had a PCI or a CABG done doesn't really mean that you need to change his antihypertensive therapy. One thing we see here in India is that patients who had a CABG think that everything is done, right? So I had a bypass surgery. How can I have another problem, right? So it is more important that you continue to take your medications, your hypertensive drugs. In fact, for example, the EMPARAGE trial, when they took out the CABG group, they very clearly showed that those who were on SGLT had a significantly lower cardiac event, significantly lower renal failure, significantly better outcome overall when they were treated with SGLT inhibitors. So I think the message should be that simply because your patient had a PCI or a CABG does not deter you. In fact, you should be more aggressive in treating their hypertension and diabetes.
At this stage, would you like to add on hydroxychloroquine for this patient?
No.
Or chloroquine for this patient?
No.
What does Bangalore?
Unless they suffer from COVID infection, why should one use hydroxychloroquine? Unless that person suffered from COVID infection, there is no need to give hydroxychloroquine.
Look, because your government of West Bengal, did it teach you any specific instructions on this?
For hospitalized patients, sir, those who are hospitalized with COVID infection, we are starting their treatment with hydroxychloroquine itself. So naturally,
not
hydroxychloroquine 5 days.
Yeah. Okay, this, no, I mean, is it possible that, when once the patient receives hydroxychloroquine, can we re-administer it after some time? Is there any contraindication for that? I'm not sure.
Sorry, I can get your question, sir. Re-administer means when?
How frequently can we use hydroxychloroquine in a patient with hypertension and diabetes? If the patient has a COVID infection, you may use it according to certain protocols.
It is only if the patient is having COVID infection, the treatment guideline is clear-cut. It is only for 5-day therapy, for therapeutic purpose. And for chemoprophylaxis purpose, for the healthcare purpose, workers or exposed person, it is one single bolus dose of 1 day followed by weekly for 6 to 7 weeks. So that is clear-cut. Still now, there is no recommendation to repeat the dose or, give more doses than recommended.
For the people who are interested in diabetes, they would like to answer this question. Is there any possibility of a protective effect of DPP-4 inhibitors against the COVID-19 infection? Dr. Dibendra. Yeah, go ahead, Dr. Taini. You have
discussing this point because if you look into the structure of the SARS-CoV-2, you find that on top of that spike protein, you have a red thing, and that basically DPP-4. So there was a concept that if patients who use DPP-4 inhibitors may be less susceptible to COVID, but that has been proven wrong. This has no basis. You can continue DPP-4 for their diabetes. It doesn't offer any protection, or doesn't it also make the patient more susceptible to COVID?
Okay. Now, best drugs for second-degree diastolic dysfunction in patients with diabetes. Dr. Prasoon Meti. LV diastolic dysfunction if the patient has.
Dysfunction is a huge, broad spectrum of term. It is just an echocardiographic finding, right? So diastolic dysfunction can occur in an hypertensive, with an LVH. It can occur in a person who is just elderly. It can occur in a person with hypertrophic cardiomyopathy. It can occur in a person with amyloidosis. It can occur in a person with ischemic heart disease. So the treatment
he has a specific patient.
Depends on what you are, your underlying etiology, right?
Yeah, diabetes mellitus.
Yeah.
Diabetes mellitus.
No, it is written best drugs for second-degree diastolic dysfunction with diabetes mellitus. So you find out why this diabetic has gone for a diastolic dysfunction. Is he ischemic, or does he have simple myocardial fibrosis, or does he have left ventricular hypertrophy or hypertension? Most of them would have some amount of left ventricular hypertrophy, and there probably the drug of choice would be a RAS inhibitor, so that your left ventricular hypertrophy comes down and your diastolic dysfunction improves.
Dr. Motwani wants to know about this electronic stethoscope.
Electronic stethoscope. See, the normal electronic stethoscope that you have, Litman, just picks up and accentuates the sound and you receive it. Okay, you have various filters, you have Bluetooth. We are not talking about that. The only non-contact stethoscope available today is called ThinkLab. Okay, we had a ThinkLab with us. So ThinkLab is a chest piece, a stand-alone chest piece. So you can put it in a polythene cover, you can sterilize it, you can do whatever is it. It has a Bluetooth connection with your headset. So you have a headset which is not in contact with the chest piece. So your nurse can actually put through even during surgery, can put it on the chest and you can listen it standing 10 feet away in your headset of the heart sounds or the lung sounds. So the ThinkLab stethoscope is a Bluetooth one, but I suppose
Bluetooth device.
You are going to have far more number of non-contact Bluetooth stethoscope. The technology is simple, right? You translate the without changing the acoustics, all you need is to put it in my headphone, right? I think it will
come up. Advantageous. It is advantageous,
yes.
right?
Yes.
It is advantage if you have one. Very good. Okay, now this is an interesting question here. The newer varieties of calcium entry blockers and their usage, like efnodipine in cardiac patients, looking at their safety profile. What do you think of the calcium entry blockers? Which ones you would like to use and don't mind using, or you would like to preferentially use? Do you have any options like that?
You have so many new calcium antagonists that have come out and flooded the Indian market. You'd be surprised to know that the new volume of Braunwald's hypertension update, I was just going through it, there is no cilnidipine, right? Because FDA doesn't allow US to market cilnidipine. But the point remains is if you look at all these newer antagonists, calcium antagonists, what is the benefit? The clear-cut benefit is edema is less. Okay, edema is less. The number of patients who develop pedal edema is less, right? Apart from that, there is no palpable difference. Okay, we are talking about nephroprotection more, we are talking about L channel, N channel, hundreds of theoretical things, but palpable difference is not very clear. Choose a calcium antagonist who has a better TP ratio, meaning that even at the end of your day, you still have a good effect on lowering of blood pressure. So a better TP ratio. Choose one with a longer half-life. And probably if your patient on CCB like amlodipine hasn't pedal edema, shift over to one of those newer ones which has less pedal edema. We know that, for example, amlodipine has a beneficial effect on increasing myocardial blood flow. Okay, anti-ischemic. Does the newer ones have that, which are more specific for L channel or N channel? We are not sure. So, okay, for an hypertensive, on a standard calcium antagonist, your patient develops pedal edema, switch over to one of the new ones. Otherwise, you continue on the ones that you still believe, like maybe amlodipine.
Yeah, here
I wanted to add 2 points, sir.
Yeah.
That along with this standard indication that pedal edema, troublesome pedal edema, not simple pedal edema, troublesome pedal edema, recurrent pedal edema, we might change from amlodipine to cilnidipine, maybe ephonidipine. Another 2 or 3 cases, indications where I keep it in mind while prescribing these newer CCBs. First is young hypertensive patients, as sir was telling, that patients having higher sympathetic drive, heart rate might be slightly higher in new group of drugs like ephonidipine, which has shown sinus rate lowering property, heart rate lowering property. It might be of some benefit with LVH, and also patient having proteinuria. Along with ACE inhibitor, there is no offers benefit. Cilnidipine has got some data which can reduce the proteinuria in diabetic hypertensive patients. So that's of the patients with proteinuric patient, young patients where the resting heart rate is slightly high, or patients having inappropriate sinus tachycardia, we can choose these newer generation CCPs, I think, provided they give good BP lowering efficacy.
Sure.
That is the first and foremost thing.
Yeah, actually, there is a little divergence of views about the clinical practice. As I can see, Tiny thinks that, this is what it is and there's no major clinical advantage, whereas, you think that there is possibly some advantage. A particular patient may benefit out of a particular profile of a particular drug. Of course, that is a clinical kind of profile of the patient. You will decide on that particular issue. Now we have here an interesting point that we refer to in this discussion already to some extent. Dr. Tiny, should we use steroids in COVID-19 patients with myocarditis with raised troponin and acute respiratory distress syndrome? Dr. Tiny.
I'm not really very sure as to what the new guidelines are, because I have not really been involved in treating COVID patients with. We know a couple of things. For example, a patient of COVID can come with an asymptomatic raised troponin. Okay, no, don't rush and do anything for them. They are just a part of the disease and they have a little raised troponin that would come down. From that one side where the patient is not suffering from anything, we can have somebody who had a fulminant myocarditis with COVID. These are patients with extremely bad outcome. And of course, they associated with ARDS, they are probably the worst possible situation. We are talking about fulminant troponin and I think most of the intensive care units in such a patient probably would expose them to steroids. but I don't know trial results whether steroid in this particular combination is beneficial or harmful. They may not make much of a difference. What is the data? Do anybody has any data on that?
Dr. Akshay has some point here.
Yeah, there is. It is interesting that the completely opposing views from the continents. In there is a Spanish report which says steroids should be given from the Spain or Italy. It was somewhere in Europe. And on the other hand, there are some reports from the US, from the United States, where they have said steroids should not be given and it may be harmful. So it is still very open, very opposite views from the continents.
Yeah, sure.
We don't know.
Can I add one thing, sir?
Yeah.
Please go ahead.
Exactly taking the cue from Akshay, sir, exactly two diametrically opposite views, two school of thoughts regarding use of steroid. Those who are telling that, proposing that steroid can be used in the very early course of the disease. Their rationale is that if you can start using steroids in the early course of the disease, you can prevent the immune-mediated cytokine storm. You can suppress the person's basic immunity, so to prevent the cytokine storm-mediated organ damage. So starting steroid early, not in the late course of the disease, or when already the things have went out of hand. Starting steroids early in a low dose to prevent the immune dysregulation might be of some help. Another school of thought is entirely diametrically opposite. They are telling that there is no benefit of steroid. As far as our data, the recommendation that we have got from our state medical advisory board, that in the advanced COVID patients who are intubated and ventilated, suspected ARDS, in those group of patients responding to standard course of therapy with hydroxychloroquine, azithromycin combination, or those who have tried tocilizumab, low dose steroid therapy can be used as a bailout procedure only. No definite data is available, but it is only to be used as a bailout, no option state.
Exactly.
So these are the three outlooks, options for using steroid.
Yeah. Okay. Now, is there any particular elaborate guidelines regarding the management of high blood pressure, management of diabetes from any society, other than asking us to continue the ACE inhibitors and ARB?
No.
Nothing else. Regarding diabetes, is there any specific guidelines from ADA or some other such society wherein, other than the insulin, everything else should be managed if the patient is an inpatient? Anything else other than that? Okay. Now let's try and answer this question. Please, 1 second. Just don't. There was a question on this any contraindication between lopinavir and ritonavir and various antihypertensive drugs, antiviral medications. And do they cause any issue of handling of drugs by the body in a hypertensive patient? There are certain drugs which can increase the blood pressure on administering.
The only thing that was shown was that, when there's a cytokine storm, a group of body believed that is driven by the angiotensin II. So maybe in those patients, in fact, there's a very small study that I have as a slide where those group of patients, those who were on ACE or an ARB, actually did better. The cytokine storm severity was lesser. But that doesn't give us a guideline as to how to treat the patient. I'm not aware.
Okay. All right, friends. In fact, we have come to the end of the session for wonderful remarks by each one of our panelists here. Tiny Nair from Trivandrum, Dr. Rai from Calcutta, and Dr. Akshay Mehta from Mumbai. And what we discussed so far is that the management of hypertension in a patient with COVID and in COVID era is not much of different in terms of managing these patients. And our goal should be to keep the blood pressure to the goal that has been described by the various societies and from time to time. In fact, even when the selection of the drugs also, even though there has been a little controversy surrounding the ACE inhibitors and ARBs, the authorities continue to believe that it is worthwhile to continue the same drugs. And managing these patients out of our offices is likely to benefit in terms of reducing the risk for the care providers, and risk in terms of for the patients also when they visit our offices, avoiding overcrowding and cross-infection. And already we are entering into the third stage of epidemic. One should be careful about it. And while in terms of managing this patient out of their hospital, home blood pressure monitoring will also be very helpful. Elaborate discussions were done by using case examples in terms of as to what will be the drug selection, what will be the follow-up strategy, what will be our kind of assessment, a clinical assessment out of office in case a particular patient walks into the office, and not neglecting the comorbid conditions, especially comorbid conditions like a diabetes and the associated underlying cardiovascular disease with or without ischemic heart disease, with or without left ventricular dysfunction. I'm glad that all the panelists, came up to the general expectations in terms of answering all the questions which are raised by the audience that we have here. All this activity, I must tell you, was made possible because of very unrestricted educational grant from Zeventis, and on my own behalf and on the panel, on the behalf of all the panelists here, along with me and all the audience across India, I thank the organizers and the sponsors for this particular program. Thank you, friends, and hope to see you soon again. Bye-bye.